All right. We are going to talk about opioid use disorder and its treatment. Has anyone talked to you about that yet?
Okay.
Is there kind of that's over my thunder? Well, what they tell you? Okay. All right. So I'll tell you what, we've got 41 slides. We may not make it through all of them. We can discuss. I will give you my unique perspective on the treatment of opioid use disorder. And we're going to talk a little bit about history. Anyone tell you about the history? Cool. I lived through it.
Like the opioid crisis.
Yeah. I mean, I was there before it started. I saw it in many iterations until the present, which is kind of struck me as a unique thing this morning when I was thinking about it. So we'll talk a little bit about that. Talk about fentanyl. We'll talk about the treatment of opioid use disorder. You can stop me from lulling you into complete slumber by asking questions. Okay, we can make this a lively discussion, or you can chill and we can make it a PowerPoint lecture. You are welcome to the slides, and that's my email. You are welcome to email me questions or call me with questions afterwards. Should you be embarrassed to ask in front of your colleagues, or if something occurs to you later, you can ask me, or you can ask me now. There's no such thing as an embarrassing question. I ask them all the time, I know. So, all right, cool. All right, treatment of opioid use disorder in the era of fentanyl. All right. Okay, so where are we now with this opioid epidemic, and how did we get here? How do we treat it? What the hell is fentanyl? And how is it affecting the treatment of opioid use disorder? So, and I have firsthand experience in all of it. Wow. Okay. All right. So any drug epidemic occurs because there is high availability, there is a low perceived risk, and you have an at-risk population that is exposed. And I will tell you that since the early 1990s, when there was an explosion of the prescription of opioids and subsequently the importation of fentanyl, that we are in an era of high availability. That is unquestionable. Low perceived risk. Again, this started with prescription opioids. Think about that, guys. This isn't heroin that you buy from some ragtag person on a street corner in a little baggie. I mean, this is oxycodone, and your doctor's prescribing it. It's got to be safe. It's got to be good for you, for God's sake. So very low perceived risk. Okay. And then you have an at-risk population. If you guys haven't been told already, there is a genetic predisposition to all addictions. And opiate use not being unique in this, there is a very much a genetic predisposition to it, which you can see clinically. And this is something that I experienced. Oxycodone, the very best of the early prescription opioids that people got addicted to. Why oxycodone? It's a really, really good pain medicine. If you guys have never had it, I've had it for an abscess in my tooth. I've had it for both my hips. And unlike Motrin or Tylenol, which is a pain medicine that you take, and I don't know what your experience has been with Motrin and Tylenol, but I'll tell you mine. You take it for whatever pain you have, and you kind of wait for it to work, and it never really works that great until you get busy doing something else, and you may look back like, oh yeah, pain's a little bit better. No, oxycodone takes your pain away in a predictable, timed way. You take an oxycodone for pain, in 20 minutes it will begin to, well, first thing you'll experience for most people is you get a histamine release. So you get a little bit of itchiness, which is great because, you know, itchiness is here, good, pain's going away. And then within 30 minutes, your pain is like significantly better. So you're sitting there with your jaw throbbing and suddenly, hey, it's not throbbing much. And then within an hour, you have pretty much maximum relief. And that's just how it works. So it's a really, really good pain medicine. But that's my experience of it. Patients with opioid use disorder, these people at this at-risk population have a different experience. So when I was treating patients who were sticking oxycodone up their nose, which was the traditional way to use oxycodone, they would come back. So many of them would say the same thing. Doc, I get a burst of energy when I take this stuff. And so I had waiters and waitresses who would take their oxycodone before they went to work to get through their shift. I had Penn students who would take their oxycodone and sit down and write a paper. This is unusual for opiates, especially heroin. You inject heroin, you get what's called a nod. You get a feeling described as God's warmest blanket. So it's a nice, warm, comfortable feeling, but you are not especially energized. People who took oxycodone got energized, some, not all. And it turns out that this energizing response to oxycodone was highly predictive to the ultimate occurrence of opioid use disorder among pain patients being treated. And I actually found a paper for that. So that's your at-risk population. All right. So history. All right. So we're going to go way back. In the 1800s, you had opiates, laudanum. Laudanum was used for pretty much anything. It was good for pain. It made people stop coughing. And before we had good medicines for the treatment of psychiatric illness, it was the main medicine for the treatment of psychiatric illness. You would give somebody opiates that would calm them down. Opiates were available over the counter. So you could go and buy whatever opiates you want. And it was used a lot to calm people down, especially women. It was really interesting that there was, and there still is, a high percentage of people, of women who have opiate use disorder, which is unusual because addictions is mostly a guy kind of thing and less likely to occur in women, with the exception of opiates. But anyway, so this is happening in the 1800s. Around about the early 1900s, we have the Harrison Narcotic Act because opiates are becoming problematic. Comes out of general circulation, it's a prescription drug, use of it goes down. Also, doctors are not allowed to treat patients with opiates for the treatment of their opiate use disorder, which is what had begun in the beginning. So that's all out the window. Opiates kind of decline in use. In the 1960s, heroin becomes a prominent opiate to be used, but not many prescription medicines. And this is where I enter into the history of this. So in 1982, 41 years ago, scary to say that, but 41 years ago, I'm sitting in a lecture hall at Tulane University School of Medicine, getting my pharmacology lecture, learning about opiates, which we were all excited because this is like a real doctor medicine. So we sit down, we get our lecture in pharmacology, and at the end of it, and I still remember this 41 years later, they looked at it, the professor looked at us and said, you never treat chronic pain with opiates, never. You can treat patients with acute pain with opiates. You can take someone who has a terminal illness and treat them with opiates before they die, but you will not give opiates for people with chronic pain because you are going to engender addiction. And that was the gospel in 1982, according to Tulane and pretty much everywhere throughout the country. So what the hell happened that we get this prescription opiate epidemic? Two things. Number one, doctors get accused of being insensitive to our patients' needs and under-treating pain, which hurts our feelings. So we don't like that. That's one thing. And then second thing, some kind of questionable research gets published saying that the incidence of opiate use disorder or opiate dependence back in the day in chronic pain patients being treated with opiates is the same as among the general population. And doctors took that to say, holy shit, it doesn't cause addiction. Let's go treat pain. And so it started. And the world soon became awash in oxycodone and hydrocodone and all kinds of prescription opiates. And so it started from, and I saw this, first thing happened is people who began problematic use used to go doctor shopping, and you go from one doctor to another. And then that got to be really complicated and difficult. And so the next thing that sort of happened, and this was all happening together, and I treated patients who were doctor shoppers. And then I treated patients who got their pills from friends and neighbors, sometimes donated, sometimes stolen. And people would go to open houses, to new houses, and they would look in the medicine cabinet for opiates, and they would take them. My patients had sort of contracts or agreements with chronic pain patients. See, if you're a chronic pain patient and you tell your doctor, I need more because I've got tolerance, the doctor would believe you and prescribe more. And so many chronic pain patients would develop stockpiles of these medications, and they would sell some or all of their pain medications to people on the street, initially directly in a one-to-one interaction between my addicted individual and pain patients in the community. And then finally it got systematized. So drug dealers would buy up these medicines from the pain patients and then sell them on the street corner. And so that was sort of the height of the prescription opiate epidemic. A couple things happened that ended that. And again, this is 2015, 2019, it's going down. Okay, this is an interesting paper. So back in the 1960s, when we had heroin users were the main patients with opiate use disorder, this is the percentage of people who started with prescription opiates or started with heroin. And again, heroin users started with heroin, that's what they used, that's what they stuck with, they didn't switch out. And prescription opiate users use prescription opiates. In 2010, it switches so that the people on heroin, most of them, the majority of them started with a prescription opiate. So that's what begins. So what happens in 2010? Doctors start cracking down on it. Guidelines are coming out limiting the use of opiates for the treatment of chronic pain. Some of our favorite pain medications, OxyContin, which you could grind up and stick up your nose, which was absolutely the favorite of my patients because you could get 60, 80, or they came in 80 milligram size, and you could grind it up and stick it up your nose. So in 2010, OxyContin changed from being something that you could grind up to being a gel cap that you couldn't stick up your nose anymore. And so doctors stopped prescribing, the favorite medicine lost its usefulness as a drug of abuse, and things started to change. First thing that happened is heroin replaces prescription opiates, which it always was. So I would treat young people in my clinic who would prefer to use oxycodone. That was absolutely the gold standard. But if the money got tight, or if their sources dried up, there was always somebody in their social group that would introduce them to heroin. And so my suburban kids would go to North Philly, Trenton, Camden, some of the places, and they would buy heroin. In Philadelphia, heroin is brown powder. That's what we use, which you can snort up your nose as easily as you can oxycodone. And it's cheap. Oxycodone went for about $1 per milligram at the height of its popularity. So if you have a habit, you would be spending $80, $100 or more a day for your oxycodone. Heroin costs $10 for a bag. You can get by on 2 to 3 or 4 bags of heroin a day. So it's significantly cheaper, and you could go back and forth. Now, the thing about heroin is there's always somebody in their social group that would say, hey, you want to get 10 times higher? Let me show you how to take this heroin and inject it. Now remember, the faster a drug gets into the brain, the better the high. So the high from injected heroin is an order of magnitude better than the high from snorted heroin or eaten heroin or any opiate. So sometimes what would happen is people would never go back. And then you've got a heroin injector, and then you've got HIV and infections and all the other problems that go along with injection drug use. All right, so first change was prescription opiates around about 2010 started to be scarce. So heroin replaces, okay? And this is what heroin is. The first drug of regular use was oxycodone back in 2005. By 2015, heroin supplants it as the drug they first used regular. Again, because by this time, very, very little oxycodone is being prescribed to chronic pain patients. So that's gone. And so now we're doing heroin. Okay. But overdose deaths keep going up and up and up. And what is it? It's fentanyl. So where the hell does fentanyl come in? All right, fentanyl, there's been 2 epidemics of fentanyl use in the United States. One in 2007, 2008. It came from a single laboratory in Mexico to selected cities within the United States. Philadelphia happened to be one of them. I lost a patient a month from November to May of that year from fentanyl overdose. It was just unbelievable. And then that lab got shut down, and then the regular source of China to Mexico. And actually, I just looked on the internet just a few minutes ago to say, does it still come from China? And it turns out, no. Precursors come to China, to Mexico. Most of the fentanyl used on the streets here in the United States comes from various labs in Mexico. Although you can make it here in the United States, I thought that may have supplanted it. Anyway, so what the hell is fentanyl? It was developed by Paul Janssen as an intraoperative analgesic in the 1970s. Later, a pain medication, again in the 1990s, people wanted to say, how can we use fentanyl? Now, fentanyl is not an oral medicine. It's either injectable or some other way besides the stomach. So patches, fentanyl patches were used for the treatment of pain. Patients learned, and the fentanyl lollipop that you would get. So it was sublingual. And so it was abused that way, but abused by clinicians first, but that was prescribed fentanyl, which is not what is abused today. There's really no prescribed fentanyl that's being used by my patients out there. So two epidemics, and neither were related to prescription fentanyl. What's so good about fentanyl? Fentanyl is really, really potent. So toxic dose, lethal dose of fentanyl versus a lethal dose of fentanyl. How many of you guys have seen this already? Okay. So it's really, really potent. So it doesn't take much. It's really fast acting when you use it the normal way, which is intraoperatively in small doses. However, if you take fentanyl every day, it hangs out in your fat. And if you happen to be someone with a higher BMI, it will stay a long time. And we learned about that. So anyway, so why is fentanyl here? And fentanyl's here to stay. In the 1800s, we had morphine and laudanum. In the 1900s, we had heroin. In this century, it's fentanyl. Why? Because fentanyl is easy to, it's a small amount. So it's easy to import and smuggle, or you can make it here. And it's so cheap. So you can get a kilogram of fentanyl for $1,700. If you put 1.5 milligrams in your fake oxycodone pill and price it at $10, you can get $6 million, $15, and you see the idea. Up to $20 million for your initial investment of $1,700. Okay. Also, you don't need poppies. You don't need poppy fields. You don't need Afghanistan. You don't need South America. You can make this stuff from chemicals that you can get from China or get from the United States in a laboratory without growing anything. Okay. It's cheap. It works. It's here to stay. And that is been our experience. So oxycodone to heroin-laced fentanyl to now pure fentanyl for most of my people. So for a while, I went through testing patients who were using opiates and getting opiate-positive urines. And now I'm getting people with fentanyl-positive urines, no opiates. And this is at the VA, which is sort of the last bastion of old-fashioned heroin. So this is what's out there on the street, guys. Any questions so far?
Is fentanyl used in any medical setting at all today?
Yep. So if you go in for an operation, you are likely to get fentanyl as an anesthetic and as pain control. That's pretty much what it's used for right now. So yeah, still, and it's a great medicine because it's fast on and fast off and works really, really well. Or you can smoke it, snort it like my guys, and you get problems with it. So, all right. Okay. So anyway, another problem with fentanyl is that it goes into fake tablets. So fake oxycodone tablets, which is not nearly as problematic as a fake Xanax tablet. If I got some guy out there using on the street who takes Xanax, he may not take opiates at all. And so you could put in your standard fake Xanax tablet enough fentanyl to put them into overdose because they don't have any tolerance. We'll talk about tolerance in a minute if we get a chance to do that. All right. So you guys already knew this, right? How many times have you been told this? It's like the third time, fourth, multiple times. Okay. All right. So who told you about it? Like who gave the lecture? Do you remember?
No, I don't think we've had one. Yeah, it wasn't me.
Okay, cool. Anyway, all right. So fentanyl comes from China through Mexico and made in the United States. It's here to stay. It ain't going away. Okay. So we've got people, and again, I've seen people addicted to oxycodone. I've seen people addicted to heroin. I've seen people addicted to fentanyl. It's pretty much the same thing. Right. Opiates. What happens when you stop taking opiates, guys?
Withdrawal.
What does it look like?
Painful, sweating.
Yeah, it's nasty. You puke on your shoes, you shake, you sweat, it's ugly. Okay, you don't like that. So you would think that that is what keeps most people addicted to opiates, right? That's what you think. Like, shit, if I stop this stuff, I'll get sick as hell. I got to keep taking it. And that is definitely a problem. However, if I take you and put you in a hospital and detox you and get, oh, we're not supposed to be detoxing. I do withdrawal management in the hospital and I set you out, you are still likely to relapse. And in fact, it is more common for patients with opioid use disorder to relapse when they are not using. Well, that actually doesn't make any sense. A lot of people who are no longer physically dependent on opiates are going to relapse at a really, really high rate. So it's more than just physical dependence. A lot of people think that if I just treat the physical dependence, then they'll be done. And actually, there's an entire industry of treating opiate use disorder from the 1960s to the 2000s, where that's what you did. You put them to a really fancy rehab. You take them to Karen, you take them to Betty Ford, you put them in the hospital, and you do the withdrawal management so that take away all their withdrawal symptoms and they're looking really good, and you set them out and they're all going to relapse. Like greater than 90% are going to relapse, and they're going to be at an increased risk to kill themselves. All right? You would think, and I thought this too when I first started treating patients with opioid use disorder, that opiate overdose was a rookie mistake. This is obviously someone early in their career. They take one too many bags of heroin and it's just literally a rookie mistake. No, that's not true. The highest incidence of overdose occurs 3 to 5 years into your drug using career and is almost always associated with a period of loss of tolerance. So putting a patient with opioid use disorder in jail or putting them in rehab is a really, really dangerous thing, because if you set them out, they're going to relapse. So this is one of my favorite papers to quote. It's a VA trial out on the West Coast. 112 patients with opioid use disorder enter withdrawal management, and 6 were treatment-free and opioid-free at 90 days. Everybody relapses. And if you do an outpatient trial, 516 patients taper with buprenorphine, only 18% were free. So everybody relapses and patients die. So it just happens. And so the worst thing that you can do to a patient with opioid use disorder is put them into rehab, do withdrawal management, and set them to drug-free treatment, just counseling alone. There is no psychiatric illness that begs for a medication like opioid use disorder, period. And so you literally sit down with your patient with opioid use disorder and you say, we've got 3 medicines that work. You can have naltrexone, you can have buprenorphine, you can have methadone. Pick. And if they don't pick, then you do the very best motivational interviewing that you possibly can do to get them to pick. Because if they don't, they're going to relapse and they're going to be at a higher risk of dying. And I'll show you that in a second. All right. So far, we're good, right? What are the 3? Oh, yeah, questions.
Just have a question, like
Sure.
what like drives the relapse? Because I know you mentioned that like you would think that
You're like a plant. All right. All right. So you guys, this is another old man story, and I apologize, but it's a good old man story. All right. There's a guy named Chuck O'Brien. Does anybody here know who Chuck O'Brien is? Charles O'Brien. Okay, famous, the world's greatest addiction psychiatrist, now unfortunately ill, mainly retired, but the smartest man I ever met, and literally the greatest addiction psychiatrist ever. Okay, so if you talk to Chuck, he would say, my goal in life was to learn as much as there was to learn about the brain that I could. And he used to say this to me when I was young. And finally, I looked at him and I said, Chuck, you want to know everything there is to know about the brain. Why the hell did you pick addictions? And then he would say, look at me and say, Vietnam. And this is a Vietnam story. Vietnam. Okay. So Chuck is older than I, obviously, of the era of serving in the Navy, being a Navy doctor, leaves the Navy, comes to the VA. So in 1973, many years before you all were born, the Vietnam War was coming to an end. There were lots and lots of GIs in Vietnam, in Southeast Asia in general, who were addicted to opiates. So President Nixon sees this and predicts a crisis and initiates what is jokingly called Operation Golden Flow, which meant that every GI leaving Southeast Asia had to submit a urine drug screen. If that urine drug screen was positive for opiates, they had to show up at their VA and get treatment. What does this have to do with why people relapse? It will be clear to you in a minute. So Chuck sees this, stands by the Philadelphia VA waiting for this epidemic to occur, and it never does. There is no vast epidemic of GIs coming back to the United States addicted to opiates. What the hell? Why? And Chuck looked and said, because there is nothing in Philadelphia that reminds them of opiate use. They left that in Southeast Asia. So the answer to your question is, what triggers relapse is exposure to conditioned reminders of prior drug use, people, places, and things. And this is what Chuck discovered. And so Chuck, when he establishes the Center for Studies of Addiction, dedicates this place to learning how to treat drug craving. And he is a big believer that if we treat drug craving, we stop relapse and people do better. And that's actually what these medications do as part of what they do. So, and that's why you're here. And so Chuck got craving added to the DSM-5 as a criteria for addiction. He was the chair of the committee that put in the new DSM-5 criteria. So anyway, that's my old man story. So we study craving. We provoke craving. Has Anna Rose Childers talked to you yet? Yeah, so she's got her fMRI thing and she shows people videos of drug use and she triggers craving and we try to stop it. At first, Anna Rose thought that if she exposed people to these craving, these people, places, and things over and over again, she would get extinction. She never did. So two problems. Number one, you can show these people this stuff over and over and you don't really ever get extinction. And number two, everybody's craving is idiosyncratic. So it's very difficult to cause extinction in every single patient. So we look for medications to stop craving, and that was Chuck O'Brien's thing. So, all right. I was wondering how I was going to work that old man story in. Sure.
I'm just curious about if there were any appetite associated drugs that they use for craving.
Well, one of the medicines that we use to treat craving is called naltrexone, which is opiate antagonist. And naltrexone's been tried for every possible addictive behavior, including food addictions and gambling addictions and everything else with mixed success. But it is a very good anti-craving medication. But that's a good question. All right. So what do we got? We got three. We already talked about it, the three, okay? What do we want a medicine to do? And this is true for all addictions. The ideal medicine stops withdrawal, reduces craving, and stops you from getting high, all right? Why withdrawal? Because that makes it really convenient. If you tell an 18-year-old person, and I've done this, that, well, I want to take you out of your home, I want to take you out of school, I want to put you in care and treatment center, and you're going to stay there for a month. And they look at you like, you're sending me to jail. Like, no, I don't want to go. And it's not just young people, I got businessmen who don't want to stop working and they just don't want to go. So if you can get a medicine where you're using heroin on Monday and you're on my medicine on Tuesday and you're not sick, that's good, because opiate addicted individuals are pathologically afraid of opiate withdrawal. They just really, really don't like it and will do most anything to avoid it. So stopping withdrawal makes your medicine convenient and attractive. Reducing craving, that overwhelming desire I just talked about. You can stop that and people will be comfortable and they'll want to take that medicine. If you have a medicine that you want to treat somebody with addiction that doesn't take care of craving and they still want to use, boy, it better be injectable or implantable and it better last for a hell of a long time because people just ain't going to take it. So, and then finally, you want to block the high because no one has ever come up with a medicine that absolutely stopped craving. And even if you did, I'm not sure it'd be perfect. But if you had a medicine that stopped you from getting high when you slip, then that greatly increases the likelihood you're going to come back for more treatment than if someone takes a medicine and gets high and they're off to a relapse. All right. So you really want to do the three things. The best you can do all three of these, the best medicine you got. All right. And all three of the medicines that we have do these to a greater or lesser extent. All right. All right. So I told you this stuff saves lives. Okay. So if you look at cumulative incidence of all-cause mortality in people after their first overdose treatment, and you follow them for 12 months, some are on methadone maintenance, some are on buprenorphine, and some are on naltrexone, and some are on no treatment at all. And you look at mortality, people on no treatment at all are dying. Okay, people on even any one of these three medications are doing better. Okay, now I'm going to show you a slide in a minute that shows you naltrexone doesn't work as well as you think. And that's true, because this only included people that got their medications monthly. All right, so if you don't, and the biggest problem with naltrexone, I'll tell you right now, we'll get to it in a second, is that people don't take it. It doesn't reinforce its use nearly as well as methadone or buprenorphine. It doesn't make you feel good. In fact, there's very little good about naltrexone. It's a once a month injectable medication. It's a shot in the butt. Nobody wants to go to the doctor and get a shot in the butt. It hurts, doesn't make you feel good, whereas methadone being a full agonist makes you feel good, and so does buprenorphine. So anyway, so any one of these three medications is going to save you. Well, it's going to reduce the likelihood that you overdose. And again, another study in which you don't look at people, don't exclude people that don't get medicated every month. The only two medicines that really work well are methadone and buprenorphine. So, but anyway, being on a medication and taking it is going to help you. All right, so what do you guys know about methadone? Does anyone talk about it? Good. It's a full agonist at the mu opioid receptor. Good. That's number one. All right. So flashback to 1970s, New York City. Dolan Neiswander, a psychiatrist, internal medicine doctor, are seeing all these people who are using heroin on the street. They give them methadone and they get better. And they call it a opiate deficiency disease. And they're going to treat it by giving an opiate. So they give them a long-acting methadone. So it's a long-acting opioid agonist. It attaches itself to the mu opioid receptor and activates it. So again, the three magic things we want it to do: take away withdrawal. There ain't nothing better than methadone for taking care of opiate. So craving, it's a full opiate agonist. It has a very nice anti-craving effect. Number three, blocking the high from opiates. That's where methadone falls down. Because methadone doesn't bind to the opiate receptor any differently than anything else. So you can take heroin and you can knock the methadone off the receptor and get high at a regular dose. So what you do to make methadone work for you is you gradually increase the dose until you confer tolerance. So much tolerance that street heroin is rendered ineffective. It doesn't do anything. It's what my guys call the blocking dose. And it's different for everybody, but it's somewhere north of 60 milligrams a day of methadone. You will get to the point where street heroin is no longer effective because you are tolerant. And that's where methadone becomes very, very effective at those higher doses. Low dose methadone doesn't do jack. It doesn't even protect you from overdose. You really do need, because tolerance is your friend, guys. That's really what saves you from overdosing and dying, is being tolerant. So wrap your minds around this. You're safer from overdose on 150 milligrams a day of methadone than you are on no methadone. Think about that. Doesn't that blow your mind? It blows my mind. Because shit, they got all this opiates on board already, and you're going to add more. They've got to be at a higher risk, but no, because of the magic of tolerance, you are protected. So methadone. Oh yeah, stop me.
Sorry, if patients, let's say, are still using heroin while they're on methadone, does that mean they'll be taking higher doses of heroin?
They'll try.
Get that
By God, they'll try, and then they'll give up because it costs too damn much to get high. And that's, the craving has gone down. They're not sick, so they've lost two real good reasons to use. Now they just want to kind of get high. So there's a little bit of craving, but it's just so damn expensive that it's just not worth it, and they stop. Yeah.
So is that why fentanyl is so popular right now?
Fentanyl, methadone is still as effective for fentanyl users as it used to be for heroin users. So yeah, you get a high dose of methadone, I'm going to block fentanyl just as good as you are heroin.
It's like way cheaper, so you could increase.
You could. But it's still hard. And I can show you a slide in a minute that shows you that methadone on patients just with heroin versus methadone on patients who are using fentanyl, it's a wash. It still works. And methadone is absolutely positively the most effective medication we have for the treatment of opioid use disorder, period.
Is it also used like if someone is like overdosing right now? Like,
No, then you're gonna give them
drop
naloxone.
into that,
No, you're gonna give them naloxone, you're gonna block that opioid receptor and stuff, so they start breathing again. Yeah. Yes,
Do these patients take these medications lifelong, or do they end up stopping?
yeah, that's a God, you guys are like plants out there, it's like perfect, okay. So you're gonna give these medications to patients for a long time. Until they make the life changes necessary to support sobriety without medications. It sounds like I've said that a lot. I've said that a lot. So what do we know about methadone? Here's what we know. In the 1960s, Walter Ling and the folks out at UCLA, who's like sort of Chuck O'Brien West, looks at methadone maintenance and starts following patients with opioid use disorder on methadone from the early 1960s to the early 1990s for 30 years. And what Walter discovered was that patients who were on methadone maintenance in excess of 5 years of continuous sobriety when they stopped did better than patients with opioid use or with less clean time. Shouldn't say clean time, less time abstinent. Okay, so 5 years is sort of like this magic number. So it's a lot longer than most people think about when they think about medications. In fact, even NIDA published something that said a year. That's bullshit. It takes a long time, 3 to 5 years of continuous abstinence, and then you can start taking people off. And some people are on it for the rest of their life. Remember, these are people who are likely genetically predisposed, at risk. Methadone's a hard medicine to be on for a long time because I told you methadone is the most effective medication that we have, but methadone is also the most inconvenient medication that we have. It is the most highly regulated medication in the world. Okay, why? Because in the 1970s, when people first started treating patients with opioid use disorder with methadone, they were really aggressive. People died. When you're on methadone maintenance, you're actually at an increased risk to overdose in the first 2 or 3 weeks until you start getting the tolerance set up in your. So people died. The DEA and the FDA got very upset about this and then put a lot of controls on methadone. So methadone can only be legally dispensed in a methadone clinic, where you show up to get your individual dose every day at the window. At the Philadelphia VA, that window is open from 6 in the morning till 8 in the morning, then from 10 until 1. So it's really hard to have a job and come and get your methadone every day at a methadone clinic. It's hard to have much of a life. So for my disabled veterans, that's generally not an issue because their social life mainly it revolves around coming to the VA, which is not the worst thing in the world for some of them. But all right, so people have to come every day. Inconvenient medication. You're bringing people together. They tend to trigger craving each other. They tend to buy and sell other drugs. So the milieu is not the world's greatest. So ever since methadone got invented and people knew that it worked, people looked for something better, something safer, something where I don't need to have people come every single day to the clinic to get their medicine. Okay. And it took until 2004 for that medicine to be discovered. Oh, here, fentanyl. Retrospective chart review, treatment retention wasn't different. 72% versus 65 versus 67. So again, treatment retention on methadone is generally equal to people doing well on it. As long as you stay in treatment, you generally are doing well. Okay.
Are there any side effects to decreasing, like after the 5 years, let's say, like how does that
Methanone's a
work?
pain in the ass to come off. Yeah, it has a withdrawal syndrome that's longer lasting and unpleasant, but not really very different than opiate withdrawal in general. So a lot of times, and it gets a little bit psychological. We used to do blind detox. You take people down to 10 or 15, and then after that, you wouldn't tell them how much you were giving them until they were finally, you would announce, well, you've been on nothing but placebo for the last week or two. Your detox is done. So that was called a blind detox. The patient would have to obviously agree to that.
Right.
So you wouldn't just spring it on them. All right, good question. Buprenorphine. Okay, well, the first medicine, well, if we want to do this chronologically, well, let's do it chronologically. So we got methadone, okay, but no one likes it because you have to come to the clinic and it's ugly. So what about naltrexone? Let's have an opiate antagonist. And we're going to give you this medicine, and as long as you take this medicine, you can't get high, you can't get re-addicted. It's a parent's dream. When I took my young people and sat down at family meetings with them, I would say, well, you got buprenorphine or you got naltrexone. And naltrexone, I give them a shot once a month. They can't get re-addicted. They can't get, and the parents' eyes just like lit up. I said, yeah, that's it. The kids, not so much. They didn't really like the idea of having to go to detox. They would much prefer to be on buprenorphine. But anyway, naltrexone. Oral naltrexone was the first one invented. It was used for the treatment of opioid use disorder. It doesn't work. We don't use it for the treatment of opioid use disorder because it doesn't last long enough. So it will reduce craving to a certain extent, but it's much better at blocking the high, to be quite honest. So it falls down because it doesn't take care of withdrawal, so it's inconvenient. And it's less effective at craving, but it's really, really good at blocking the high. That's where it shines. Anyway, so you don't limit it to a methadone clinic. So when it gets on the market for the treatment of opioid use disorder in 1984, everyone thinks this is great. And then no one likes it for the reasons I just said. And so it's certainly in its oral form, it is ineffective. And even in its injectable form, it leaves something to be desired. So that's naltrexone. We still use it. It got approved. Yeah. So this is data from the Russian trial. Naltrexone for the treatment of opioid use disorder was approved based on trials in Russia. Why Russia? Because in Russia, methadone and buprenorphine are illegal. It's the only game in town. So my friend Evgeny Krupitsky got naltrexone approved in the United States based on Russian trials. So interestingly, the FDA will approve a medication to be used in the United States based on trials done anywhere in the world, but you have to have at least one trial done in the United States. So I participated in that one here, but this is the one that got it approved. So naltrexone works. You give it, like I said, it's a shot in the butt. And again, and it just doesn't make you feel good. So they'll get the first shot and then they may stop. Yes.
How expensive are these treatments?
A naltrexone injection will cost you about $1,000 a month. Insurance companies will pay for it. You know why? Because keeping people out of the hospital is where it's at for an insurance company. That's where they save money. So if you keep people on these medications, they don't go in the hospital, then the expense of the medication becomes minuscule compared to treating people in a hospital. So every insurance covers naltrexone. Medicaid does.
Rehab and other drugs.
Say that again.
Are they covered by insurance?
Mm-hmm. Yeah. I mean, people are dying out there, and pretty much at this point, all the medications they're going to talk about are fairly available. People can get admitted for detox. People can get on buprenorphine or methadone pretty easily. They're trying to grease the skids. Now, having said that, I'll tell you that if you went back, if you kind of looked at the slide I showed you at the beginning about overdose, it ain't stopping, guys. You know, even though I got these great medicines, it ain't stopping. So you think to yourself, well, Kyle, these medicines obviously don't work very well because people are taking them and they're still dying. No, the truth of it is it's only because 10% of people with opioid use disorder get on these medications still, even now in 2023, which makes no sense to me. But this is what's happening.
So it makes me think that has a lot to do with lacing the fentanyl. So a lot of people that take it don't know that they're taking it.
Yeah, you know, a lot of people don't know they're taking fentanyl. A lot of people don't care that they're taking fentanyl. The biggest problem with fentanyl is getting people started on medications like buprenorphine and naltrexone, because it just stays in the system so long. And to get you started on naltrexone, you have to be completely not physically dependent. And it just takes a long time with fentanyl, and people don't want to stay in the hospital that long. Outpatient withdrawal management is difficult. So getting people started on naltrexone and then buprenorphine. Let's just look at that 1 second. All right, so buprenorphine. It's a partial agonist at the mu-opioid receptor that has a higher affinity for that mu-opioid receptor than any full agonist. What does that mean? It means I can give you buprenorphine and it's going to take care of your withdrawal symptoms. So it's as good as methadone for treating opioid withdrawal. Very good at reducing craving because it's an agonist. It has activity at that mu-opioid receptor. It makes you feel good. It'll take care of your craving. And you don't have to wait to get tolerant to it for it to stop you from getting high, because it actually binds to that opioid receptor more tightly than heroin or oxycodone or fentanyl. So I can get you to a blocking dose in about 2 days. So, and you can't overdose and kill yourself with it like you can with methadone. So it's safe enough to give at a doctor's office. So you don't have to go to a methadone clinic. And as of maybe 6 months ago, any doctor in the world now can prescribe it without any special training like we had to do. But so it's out there, takes care of withdrawal, takes care of craving, blocks the high, not as good as methadone or naltrexone, but pretty good. And so it's safer to use than methadone, more available than methadone, and it works pretty good. Not as good as methadone. In head-to-head comparisons, methadone always beats buprenorphine. And again, this is actually out of date. I didn't change that. No more specialized training, no more waiver. It's just any doctor can prescribe it. Prone to diversion and abuse. Why? No self-respecting heroin user would ever take buprenorphine to try to get high because it's a partial agonist. It doesn't work. And we live in Philadelphia where you can buy heroin for $10. That is really good. So why would you divert buprenorphine on the street for withdrawal management? If you're down to your last $10 and you're a heroin user, you can buy another bag of heroin and be sick in 6 hours, or you can buy an 8 mg tablet of buprenorphine and you can cut that thing into a quarter and take it and take care of your withdrawal for the 24 hours. So it's done for homemade withdrawal management. Some people will go out and do a homemade Suboxone maintenance treatment just by buying street Suboxone. So that's mainly why it's diverted. So again, not as good as heroin. All right. So what was the question I delayed? What was your question?
I was asking if a
Buprenorphine.
lot of people are still dying because they don't know that they're taking them.
So again, most people die from overdose because they go in for treatment or they lose their tolerance for whatever reason, come back out and use. And you're right, now with fentanyl and all the heroin, it is very difficult to gauge and know exactly. So yes, you are much more likely to die from fentanyl. Obviously, you're much more likely to die from fentanyl because you just don't know how much you're getting and how much you need to use. So the biggest problem with fentanyl is getting people on buprenorphine because because buprenorphine has a higher affinity for the mu-opioid receptor than any full agonist. If you have a full agonist sitting on that receptor and I give you buprenorphine, it's going to knock that full agonist off the receptor. Activity at the receptor is going to go from like this much to like that much, and you're going to experience that as withdrawal. It's called precipitated withdrawal. It drives heroin users crazy, and so the popularity of buprenorphine has significantly decreased on the street because of precipitated withdrawal, because fentanyl hangs out in your system for like 3 or 4 times as long as heroin. It's almost like a methadone out there. Withdrawal takes a really, really long time. So it's difficult to get people started on buprenorphine, difficult to get people started on naltrexone. So this is the biggest problem that we have with fentanyl. Once people get on these medications, if they stay on it, it'll protect from the high from fentanyl pretty good. So, yep.
Is Suboxone still used?
Suboxone is buprenorphine.
Oh, okay.
What is Suboxone? That's a good question. Thank you. All right. So buprenorphine is sold in the United States in a combination product of buprenorphine and naloxone. The United States, and another old man story, has a history of combining naloxone with oral or sublingual medications. Why? To prevent IV diversion. And all started back with Tolwyn back in the 1970s. But anyway, so Suboxone is the combination of buprenorphine and naloxone at a 4-to-1 ratio. So it makes it less likely to be diverted and used injectable.
What about sublocade?
Sublocade is long-acting injectable buprenorphine. So it's a buprenorphine injection that will last a month. It's a wonderful product. It gives you the agonist feeling that buprenorphine gives you. So you feel comfortable. People like it. The shot hurts, and that's the biggest problem. And there's another product called Brixadi, which I was involved in both of these to get them started. Brixadi is like an order of magnitude more comfortable. Sublocade needs to be given in your belly, and it hurts like hell. Brixadi, on the other hand, is about half the volume. It can go pretty much anywhere you could give an insulin shot and it doesn't hurt. Unfortunately, Indivior, which is a spin-off company of Reckitt Benckiser, had a lot more business acuity than the wonderful people that made Brixadi. And so Brixadi never, it took them this long to get approved. They were actually, I was at the meeting, the same meeting, they discussed Brixadi and Sublocade. Sublocade got approved, Brixadi didn't, and it's taken, and that was before the pandemic. So 2018, 2017, long time. And so Brixadi's finally got approved and it's going to be available. And when it does, it is much better than Sublocade.
Like I did this phone screen that I was talking to this person and like he hasn't used heroin for 2.5 years.
Okay.
But is like on 10 different medications, like is on Suboxone and also takes like gabapentin and the Sublocade. And I was just thinking that like isn't it in a way that like now he's just addicted to all the medication that he
That's
takes
another good
and
question.
not
So what does it mean to be addicted? What does it mean? Seriously.
mean something, I guess. Like,
Okay, well, a lot of people take it a different way. And again, I've heard this. I mean, in the old days, the patients would say, well, you're just trading one addiction for another. Okay. Opiate use disorder certainly includes physical dependence. Okay, absolutely. And tolerance. But it also includes the dangerous use. So you give up important social functions to use. Use despite adverse health consequences. You spend a lot of time using, so it's got a lot of bad stuff that goes along with just the use of it. I mean, I give people medications all the time that if they stop, they're going to get sick, but they're not addicted to it. So you're not addicted unless you have these other aspects of the use disorder as opposed to physical dependence.
but like, wouldn't they get physical dependence if all of a sudden they just stop taking all the medications that they use?
Well,
so they don't
If a medication causes physical dependence and you stop it abruptly, by definition, you're going to get a withdrawal syndrome. So that's not going to be good. So yes, in my mind, I would love my people to make all the life changes necessary for them to get off these medications eventually, which sort of makes me different than a lot of other current addiction doctors out there who say, as long as I give you this medicine, you're safe from overdose, just take it and don't stop. It's like, no, I want people to get into recovery. I want them to get better. I want them to get off these medicines. I want them to have a life. I really do. But I'm more patient than I used to be. So
What are some of the physiological side effects of all of these medicines?
that's a good question. Buprenorphine will give you a headache. It will give you constipation like any other opiate antagonist, partial agonist. May affect liver function tests, but not really. So methadone can make you sleepy. Methadone can cause your legs to swell up. Methadone has effects on sexual function. It's not the world's friendliest medicine. Buprenorphine, on the other hand, doesn't have a lot of really bad side effects. Naltrexone can make you nauseated. That's the biggest one. But they're not terrible. But those are good questions.
Nothing like hypertension or cardiovascular.
Not much. No, actually, opiates are really safe from cardiovascular effects. And I mean, they don't really have a lot of long-term effects. You can keep somebody on methadone. And again, cardiovascular obviously causes vasodilation and then swelling in the legs for sure. And so a lot of methadone guys will get that. So that's a potential problem, but it doesn't happen to everybody. These medicines don't have, by and large, really ugly side effects. They really don't.
Okay, so I know we're talking about opioids,
Sure.
but that whole question about addiction versus dependence made me think of cannabis and a lot of people who say that, like I'm not addicted to this, but they are physically dependent and, they like smoke weed every day or like something like that. So I wonder when it stops being dependence and starts being addiction. And then you talked about,
Right.
how negative
It's when it
effects on
affects your life.
stuff like that.
When bad
Like-
things are happening to you and you continue to use.
because of it, right?
Yeah.
But does it have to, like, do you have to get to that point for that to happen for it to be addiction?
To have an opiate use disorder, you've got 11 criteria. You get 2 to 3, you're mild. You get 4 or 5, you're moderate, and you get 6 or more, and you're severe. But you can, and so it takes more than just physical dependence. It takes more than tolerance. or withdrawal symptoms for you to have a use disorder for anything. So again, you've got to continue to take your drug despite bad things happening in your life, either physical or social. You end up giving up important activities because of your use. You don't go to work anymore. You don't take care of your family. All you do is use drugs all day. I mean, you got to have those kind of symptoms for you to have a use disorder. So,
does that mean
yeah.
you can't really get addicted to?
You can get addicted to cannabis for sure, and bad things happen to people. Cannabis is not a benign thing. It's probably less dangerous than some of the other drugs, and I get a lot less concerned about cannabis than I do cocaine, opiates, or even alcohol. But yeah, people get into trouble with cannabis. They do. Not as many, but yeah.
For people using opioids and also other substances, how does that affect like which medication you choose to use? Because I know like with naltrexone, sometimes that's used for like alcohol use disorder.
Yeah, and you'd think that patients with opioid use disorder with comorbid alcohol would take care of both. It doesn't. Actually, the studies haven't really borne that out so much. So, okay, so methadone increases intracranial pressure. So if somebody has like a tumor or something that makes the brain swell up, then you can't give it to them. Sometimes methadone can cause EKG changes in the electrical conductivity of the heart, which contraindicate its use. So EKG, increased intracranial pressure, kind of makes you not want to necessarily use methadone. Buprenorphine, pretty much, unless their liver is totally trashed, you can pretty much give it to them, and there's not a whole lot of contraindications. Naltrexone obviously blocks opiate receptors, so if they need opiate pain medication, you can't give them naltrexone. And that actually becomes an issue too. When people who are on naltrexone need to come in to get surgery, then that becomes a mess. And that's not a benign thing. That's a problem. So you kind of let people pick. And I do that. I sit down and I say methadone, naltrexone, buprenorphine. Okay. If you've got really bad pain and you want to be on a really strong pain medicine, there ain't nothing stronger than methadone. And so you may want to pick methadone for that reason. If you don't want to come to a methadone clinic and you don't want to go in and have withdrawal management done to you, then buprenorphine is for you because you don't need withdrawal management. If you don't want to be on a medicine to which you will be physically dependent, and this is one of the main things that people like about naltrexone, is naltrexone's for you. So for instance, if I put you on methadone, we kind of already talked about that, and you want to get off, then you're going to go through withdrawal. And a lot of people don't want that. And a lot of people don't want to be on a medicine where if they don't take it, they're going to get sick. And so some people will choose to be on naltrexone for that reason. And that is the main reason why my folks choose naltrexone, because they just don't want to be on something that they need to be physically dependent on. So, and then people generally choose buprenorphine because it's convenient, it's easy, and they don't need to go through withdrawal to get it. So, all right, 2 more minutes, or maybe not. Are we done? Am I over time yet?
I think we got a couple minutes.
Couple minutes. Okay, yeah. It's 11:58.
Tell us a bit like about what you do specifically, like. Yeah.
What do you mean?
Like what job, like where you work, like where you work.
Sure. Right now I do all my clinical work at the Philadelphia VA, at the Addiction Recovery Unit, where I prescribe a boatload of buprenorphine, Suboxone, and other stuff as well. I ran the Charles O'Brien Center, which was fee-for-service University of Pennsylvania addiction treatment program, which I made it very successful, but with way too much. Like I was a victim of my own success and just got burned out and said, no, I got to get away from this. And so I went down to the VA, which if you're a veteran, there's just so many more services available. It's just wonderful to work down there. Like any kind of group therapy you want, you got housing problems. They just take such wonderful care of these guys and women too. And then when I'm not doing that, then I'm up here doing medications. Currently looking at a combination of pregabalin and lofexidine to rapidly treat withdrawal. So I can get people on Vivitrol quicker and easier. Cariprazine for the treatment of comorbid cocaine and opiate use disorder, clavulanic acid for cocaine use disorder. I'm a cocaine researcher. I came here in 1990 when you guys, how many were born in 1990? Anybody? You were, well, maybe. So before you guys were born. And last old man story, I got 10 seconds. This crack cocaine was out there and people were using it and it is so addictive. And it just got to be such a huge problem. There were drive-by shootings. Famous basketball players were like dying from cocaine on a basketball court. So people got really scared of it and there was no real good treatment for it. So there was just a boatload of government money available for treatment. And this happened right after Chuck had found that naltrexone worked for alcohol use disorder. And so he had developed a medicine and he was part of methadone. So Chuck figured he had opiates licked, he had alcohol licked, and now cocaine was going to be his thing. And I was going to work with him to do it. And we never got quite as far as Chuck did, but I did cocaine research until, this opiate epidemic came out, and then I switched to opiates. So that's kind of what I do. I'm a medication development guy. So, all right, guys, thank you.